Morning, good afternoon, good evening, again to all listeners. Um, Welcome back to this webinar series on immittance audiometry. Today, I'm delighted to introduce Dr. Sreedevi and Dr. Venkatesh Aithal, who are consultant audiologists at the Audiology Department at Townsville University Hospital, Queensland. They work at the Hearing Research Unit for Children, and their interests primarily lie in immittance audiometry, wideband reflectance, and also electrophysiological testing for children and adults. Sridevi ma'am, over to you now.
Thank you, Imran. First of all, I just would like to say a big thank you to ISHA and to Srividya and Imran for the presentation today or the webinar today. Let's go without much further ado. We'll start with the presentation. So we'll cover a little bit about why do we need to do wideband absorbance and some principles of wideband absorbance and some normative aspects and its application and differential diagnosis of media pathologies. So we'll try and summarize the research so far, as well as the work that we have done here in Australia as well. So it will be a bit of a summary of the clinical experience as well as the research so far. So let's start with the 226 Hertz tympanometry. We all know that it's the standard test for mid-ear assessment, and probably that's the one that's used worldwide by all clinicians. The main reason for using this particular frequency was not because of its application to middle ear as such, but it was more of the convenience of the equipment rather than the test performance of the 226 hertz. At this frequency, we know that the ear canal acts as a hard wall cavity, and it's much easier to measure the compliance that way. And in terms of the equipment, the compliance and admittance have a one-to-one relationship at this frequency. So there were a few reasons for using the 226 hertz tympanometry when it started as a mid-ear assessment tool. Now let's look at the limitations of this 226 hertz tympanometry. We know that the classification is limited to 3 patterns. Although the A type has got an AS and an AD subtypes, it's basically A, B, and C patterns. And the 226 hertz tympanometry is quite useful in the identification of proximal pathologies. That is, if there's a tympanic membrane perforation, eustachian tube dysfunction. Those are the proximal pathologies that tympanometry is quite helpful. But it's not that helpful with distal pathologies, such as ossicular fixation or superior semicular dehiscence. In those cases, you get a standard A-type tympanogram. So it's not that helpful with distal pathologies. And testing has shown that if you compare the test performance of the 226 hertz tympanometry, it's not that useful in detecting otosclerosis. Yes, there are other things that are useful with otosclerosis, for example, the case history, the audiogram pattern, but the tympanometry per se is not that useful in detecting otosclerosis. And even same thing with ossicular chain discontinuity, when AD tympanogram, AD type of tympanogram is considered, it has detected only about 42%. So with distal pathology, the performance is not that great. And if you look at application of 226 hertz with infants, we know that it's a very poor predictor of the mid-ear function in case of infants. So even if there is mid-ear effusion, you can get an A-type tympanogram with infants. Though there are objective measurements such as gradient tympanometric width, these are not commonly used measures across the clinicians. So we tend to mainly use the A-type, or we describe the compliance, and we go for the mid-ear pressure and then the volume. The gradient and tympanometric width are not commonly used parameters with the 226 hertz tympanometry. So that begs a question. So why do we do the wideband measurements of, can't we improve the 226 hertz? Yes, in that case, multi-frequency tympanometry has come to use, but still it is testing individual frequency, one frequency at a time. 1000 hertz tympanometry does better than 226 hertz tympanometry in identifying miliar function with infants, but when it is compared to the other tests, it's still not that great. Studies have found that probably 1000 hertz tympanometry is better about 75%, 72 to 74% of the time. It can identify the miliar effusion. So even with infants, when there is effusion, it's still we can get a normal 1000 hertz tympanometry. And also, I think we need to ask a question to all the audiologists. Is there any other test that uses just one frequency? We use tympanometric assessment, and then we do the whole frequency between 250 to 8 kilohertz. And sometimes we do go beyond that with high frequency tympanometry. You take autoacoustic emissions, for example, that takes a range of frequencies. ABR, tone burst ABR. So all the tests that we do takes a range of frequencies. But when it comes to tympanometry, we are stuck with only one frequency. And that limits the clinical interpretation a lot. And as I have said earlier, we tend to go for more of a qualitative classification of tympanogram than the quantitative method of tympanogram. And when it comes to 1000 hertz tympanometry, there's not much uniform consensus across the world. Some people say, okay, yeah, just draw a line between the positive and then the negative ends. And then if you get a positive peak, that's a normal tympanogram. But then some people say a single peak tympanogram is normal one. And some people say double peaked or multiple peak, it's still a normal one. So we don't know what exactly is a total normal class or a description of 1000 hertz tympanogram in terms of consensus across all clinicians. Can we go above 1000 hertz? We can, but then because of the effect of standing waves, we cannot go for tympanometric measurements above 1500 hertz. And lastly, tympanometry was developed in the 70s before the digital technology. And we still are maintaining the same classifications. And I think it's time that we challenge ourselves and our practice. I'm not condemning tympanometry, but what I'm saying is when we have so many advancements in all aspects of audiology, tympanometry it's time for us to question or challenge the tympanometry and see what else we can use instead of tympanometry. So, and that's what brings us to the wideband measurements. So let us look at wideband acoustic immittance measures. When we say wideband acoustic immittance measures, it is a whole family of measures. It includes wideband admittance, reflectance, absorbance, phase angle, resonant frequency, a lot of different measures. But in today's presentation, we'll be focusing mainly on the wideband absorbance. And that's because majority of the work in this area is done on the wideband absorbance compared to any other measures of wideband immittance measures. Before we go on to the principles, I just talk about the equipment used. There are two companies that make the wideband absorbance measurements. This is by the Interacoustics. This is a Titan equipment by the Interacoustics. So this has got a bit more capability that I'll describe a bit later. So this is one, and the other one is the Mimosa equipment. So these are the two companies that produce the wideband absorbance measurements. Earlier, it used to be only the research equipment, and but now the clinical units are available. So that's why, like in the clinical usage has starting to take up. With Mimosa, there are two kinds of equipment. One is the Autostat and the other one is Hear ID. Autostat is PC independent, whereas Hear ID is, it requires a PC. And Titan, of course, works only with the laptop. To just give you a background, the figure on the left, That's the research equipment. So when the wideband absorbance started, this is how the equipment would look. And this is what we used to collect a lot of our initial research with the newborn infants. It was very bulky equipment. We had to go from second floor to the ground floor, pushing this huge, heavy equipment. And that later on, they release the wideband clinical unit, which you see on the right side, which is much more sleeker and much more manageable equipment. So the clinical unit, it's much more user-friendly compared to the research unit. We started the our research on two different technologies at the same time. We did the wideband absorbance, as well as we did a lot of work on sweep frequency audiometry as well. And with sweep frequency, we collaborated with the Japanese universities, but we're not going to talk about the sweep frequency today. It's just only the wideband absorbance. Okay, let's go on to the principles of wideband reflectance. If you look at the earlier literature, everything was described in terms of wideband reflectance. So wideband reflectance, in simpler terms, you give some energy and you see how much of energy is reflected back. So if the energy reflectance is also called the power reflectance, or even just reflectance or wideband reflectance, is the amount of energy that is reflected in relation to the energy that is input. So if the all the energy is reflected, then the wideband reflectance is 1. If there's no sound that is reflected, it is 0. So this is a basic principle of wideband reflectance. So wideband reflectance, it is a technique where a complex sound is presented and the amount of energy that's reflected is calculated. So it's the reflectance of the backward to the incident wave. So when you calculate the wideband reflectance, it is different to the admittance that's calculated using a 226 Hertz tympanometry. With tympanometry, when you keep the probe depth or the insertion makes a difference in terms of the measurement of the ear canal. So whereas with the reflectance, it's not that affected by the probe insertion depth, because the way it calculates the whole admittance is in a very, very different way. This calculates the reflectance and the phase angle, and then the admittance is derived from that. So there's no pressurization of the ear canal when the admittance is calculated. And with the wideband reflectance, it is also called as the equivalent admittance that is measured. I'll just come to it a little bit later, but when we say the admittance calculated with the wideband reflectance, it's a different way of calculation or measurement compared to the 226 Hertz admittance. In 226 Hertz tympanometry, we pressurize the ear canal and then measure the admittance, whereas with the reflectance, we can still calculate the admittance, but it's derived through the reflectance measurements. So with the wideband reflectance, we can derive the admittance magnitude as well. So the two aspects that can be measured, one is the admittance magnitude, the other one is the phase angle. So reflectance is a complex mathematical equation that contains both the reflectance magnitude as well as the phase angle. So if you look at wideband reflectance of normal hearing adults, you can see that the reflectance is highest at the very low frequency, and again at the very high frequencies. The reflectance drops in the mid frequency range around 1000 to 4000 Hertz and then increases. So the reflectance is highest on either side of the spectrum, and it's low in the mid frequencies. Now, if you look at the threshold of audibility, so we know that the threshold of audibility is better in the mid frequencies, and it is high in the very low frequencies and then the high frequencies. That is probably because of the energy that's is reflected in these low frequencies and the very high frequencies. You can see the similarity in the energy reflectance to the threshold of audibility. This is just one observation that we like to compare with. Okay, so in the previous literature, up to about 2013, most of the research or work was done on wideband reflectance. So if you look at any of the literature, you see all the studies citing wideband reflectance, and some studies were measuring wideband absorbance. Now, there was a consensus of all the specialists who work in the area of wideband absorbance in 2013, and then they came up with some of the consensus relating to the wideband immittance measurements. One of them is that absorbance should be used rather than reflectance. And also earlier, with the absorbance measurements, I said even the admittance can be measured. The admittance can be expressed either in terms of millimos or in terms of decibels. And if it's measured in the terms of decibels, it's also called as transmittance. So they said we should not use the word transmittance, and only the word absorbance, the term absorbance should be used. So after 2013, if you see any of the studies, they're all in terms of absorbance rather than reflection. Now, if we look at the relation to reflectance versus absorbance, they are the reciprocal. The absorbance is nothing but a reciprocal of reflectance. So though the equipment measures the reflectance, as audiologists, we are also familiar with the A-type tympanogram. We cannot deny that. So if the results are presented in terms of absorbance, so it's much more appreciated by the audiologist. So, and that's the main reason why absorbance was preferred to compare to the reflectance, but they're nothing but reciprocal. Now, to give just a small story to that, when I was doing my PhD, I did a series of studies, and when I had to do my thesis, I had to put all these articles into one. The first article was presented in terms of reflectance, and the subsequent in terms of absorbance. So I had to convert literally the whole paper and all the measures from reflectance to absorbance. So it's just nothing but a reciprocal of reflectance. So let us look at it here now. So when you give any energy to the ear, the incident energy, there's some energy that gets reflected and some energy that gets absorbed. So the amount of energy absorbed in relation to the incidence energy is wideband absorbance. Wideband because it's a signal that contains a wide range of frequencies, and it measures the amount of the energy being absorbed. So absorbance, as I said, it's nothing but 1 minus reflectance. So if we have measured reflectance earlier, so it's just a reciprocal of that. So if you look at wideband absorbance, we can either present it as in terms of percentage or a decimal. So if no energy is absorbed at all, if all the energy is being reflected and no energy is being absorbed, then absorbance is 0. And if all the energy is absorbed, then the wideband absorbance is 1. Or you can say it as 100%. If 30% of the energy is absorbed by the middle ear, then the absorbance is 0.3. Whether it's like 0.3 or 30%, it's the same concept, but measured, provided in two different mathematical scale. That's all. Because if you look at the studies, some of them present in terms of percentage, some of them present in terms of the decimals between 0 and 1. So wideband absorbance. Wideband absorbance can be measured under two different conditions. One is under ambient pressure condition, and other one is in the pressurized condition. When I say ambient condition, it is like when you present the OAEs, you keep a probe, there's no pressurization. You keep a probe and you present a click cell. And you present a series of 32 clicks at an intensity of 100 dB SPL or 65 dB NHL. And you measure how much of energy is absorbed by the middle ear. In terms of tympanic peak pressure, it is like tympanometry. You vary the pressure from plus 200 to minus 400, minus 300 decapascal, and you still measure how much of energy is absorbed at individual pressure points. I'll come to that a bit later. I'll talk about the absorbance at ambient pressure condition, and then we will move on to the pressurized absorbance. Now, let's open give an example of wideband absorbance for a normal adult. And you can see here, this is given in terms of percentage. And when the results are presented, they're usually presented as a normative range, which is the 10th to the 90th percentile. And then the absorbance of an individual person is plotted in that normative range. So you can see that the absorbance is very low at the very low frequencies. It increases, and then it's the highest between 1 to 4 kilohertz, and then again drops down. This is a normal absorbance, and this is at the ambient pressure condition. There's no pressurization of the ear canal. So before we go on to that, I'll just quickly cover the spring mass and friction model of the Media system. This has been covered a lot in detail in the previous webinar series. So I'm not going to talk much about it, but I'm just going to briefly touch upon that. Now, the middle ear is a combination of a lot of the structures that add the mass to the middle ear, and they include the ossicles, and then the tympanic membrane. So they all add the mass to the middle ear. And then we also have the compliant structures. We have the muscles, and then the ligaments and the tendons. They also as they represent the spring of the system. Now these whole complex system, and then you can see that each individual structure has got its own way of responding to the signal. So when you present a signal, each of this structure can absorb some energy and reflect some of the energy. And some of these structures are proximal to the tympanic membrane, some are distal to the tympanic membrane. So each component has got its own characteristic. So the mass component, okay, I'll just go to the next slide. So we can combine all of these into a single mass and a spring model of the Media system. Now, in this system, the spring components of the middle ear, whenever there's a pressure, the forward pressure, they store the energy. And then when the tympanic membrane goes back, or when they recoil back to their position, they reflect a lot of low frequency energy. So the stiff components of the middle ear system, or the spring component, they reflect a lot of the middle ear, of the low frequency energy. On the other hand, the mass component of the middle ear, they reflect a lot of the high frequency energy back. So if you look at this, if you look at the resonant frequency, then as the stiffness increases, then so that the more energy, the low frequency energy gets reflected, and as the mass increases, you can see that the higher frequencies get reflected. So this is the basic mass spring function of the middle ear system. The friction component doesn't act so much for the middle ear, for the wideband absorbance component, as much as the spring and the mass components. So if you look at this one here, so the lot of energy is reflected in the low frequencies and the high frequencies, and less energy is reflected in the mid frequency. But if you plot that as an absorbance one, so you can see that the less energy is absorbed in the very low frequencies and the high frequencies, and then a lot of energy is absorbed in the mid frequencies. So if you look at the previous literature, they're presented in terms of reflectance, and the later ones are presented in terms of absorbance, but they explain the same concept. this is again reiterating. So if the stiffness increases, you can see that a lot of stuff in a low frequency energy is reflected, or less frequency is being absorbed. And as the stiffness is reduced, you can see that the more of low frequency energy is being absorbed. The same thing, like, as the mass increases, you can see that the absorbance in the higher frequency is reduced. So the mass and the stiffness make a big difference in terms of the energy being absorbed or reflected in the mid-layer. Let's look at some of the normative aspects of age on wideband reflectance or absorbance. The main one is the effect of age. So in a newborn, if you can see here, in a when you see the absorbance pattern in a newborn, the absorbance is very high across the whole range. So compared to a normal adult, you can see there's nearly about 50% of energy absorbance in the low frequencies. It increases to about 70 to 80% in the mid frequencies, and again comes down. But still, it's much higher across the range in newborns. And as the infant ages, the absorbance sort of, pattern changes, because in a newborn ear, it's a very immature ear, and we know that a lot of development happens in the first few months. The inner ear is fully developed, and that's why we can measure, do the ABR, and then we can measure the hearing. But the mid-ear is a very immature system. The outer ear and the mid-ear undergo enormous developmental changes in the first 6 months. And that is reflected in terms of the wideband absorbance. So if you look at here, this is a series of absorbance measurements on infants age 0 to 6 months. You can see the first 4 months and then the 6 months. And by about 6 months, you can see there's a huge drop in terms of absorbance. There's a lot of things that happen around between the 0 and 6 months. One is there is the ear canals starts to there's different the stiffness of the ear canal increases. The bony portion of the ear canal starts to develop. The tympanic membrane the more there's a lot of effusion in the mid-ear is reduced in the mid-ear. The ossicles become more ossified, and so there's a lot of mid-ear changes that do occur in this developmental period, and it's most evident by about 6 months of age. And that is why it is very important to use the age-appropriate measurements when we assess the infants. So what holds good for a newborn doesn't hold good for a 6 month. And this is the reason also why that up to 6 months of age that we need to use 1000 Hertz tympanometry, because 226 Hertz is not that great in assessing the mid-ear function in the newborns. If you look at the development of wideband absorbance, now you look at the absorbance at 1 month of age and about 7 months of age. There's so much of developmental change that has happened, and then you can see that the middle ear has started to stiffen, because the stiffness elements are the ones that reflect the low frequency energy there. So you can see that the absorbance has reduced in the lower frequencies. It is starting to come down in the high frequencies. It's still not the same as an adult pattern, but there's a lot of changes that compared to even a 1 month old. So even in the first decade of life, there's a lot of changes, very subtle, but a lot of changes do occur in the first few years of life. And then by about 7 to 10 years, the adult pattern would have reached, even after the very slight subtle changes in there. So it is very important to use the age-appropriate measures or the normative measures when we are assessing the wideband absorbance. So age is a major factor that we need to consider. There are other factors that can influence, and one of them is the effect of the ear, whether the right and the left ear, and then the gender and the ethnicity. So if you look at the ethnicity, there are some studies that have compared mainly Caucasian and Chinese, and then they have said there is slight difference between the two groups. Not that significant to warrant a normative to different groups. Although one study has said, like, when they're assessing autosclerosis, they said ethnic particular norms has helped to differentiate autosclerosis better than having a combined norm. But most of the studies do not show a huge clinically significant difference. Statistically significant difference are found, but they're not as clinically significant difference between the ethnic groups. We studied a group of indigenous versus non-indigenous children, and indigenous children in Australia have a very high incidence of miliary diseases. So when we compared, there was no difference between the indigenous and non-indigenous group. However, a very interesting finding was that there was a significant difference between in the absorbance measurements of the Aboriginal and the non-Aboriginal infants at birth. So even when they passed a test battery of 4 different tests, their miliary function was, the absorbance was low compared to that of the Caucasian infants. So we don't know whether this is related to the ethnicity or whether it's related to their miliary function, whether it's, they had an abnormal miliary function. So that is sort of something that we're not clear of why the results are. But when we looked at an older age group, there was no significant ethnicity differences in terms of ethnicity. And if you look at right versus left ear, there's a very small, probably slightly statistical difference, significant difference at some of the frequencies, but nothing clinically significant difference between the right and the left ear. So we can use the same norm across both the ears. Similarly, that's the effect of the gender is not very. It's still equivocal. Some studies have found very small difference between males and females, and some studies have not found. And even if there's any difference between the males and females or the ethnicity, it's usually attributed to the body mass and then the head shape and the size and the ear canal volume. But we don't have to, at this stage, we don't have to have separate norms for either males versus females or for the right and the left ear. So in summary, yes, there are statistical differences were found, but clinically they're not that significant across the groups. So this is about the wideband absorbance. Let's go to the wideband tympanometry. Now, in it, wideband, in traditional tympanometry, it's you measure the admittance or compliance, and we test up to about 1000 hertz, and you can get a Y tympanogram, or you can even get the B and G tympanograms. With wideband tympanometry, it's measured in terms of absorbance. So you measure the wideband absorbance across different pressure points. I'll just go into a bit more detail in the coming slides, but I'm just comparing it with the traditional tympanometry. It provides all the information that you get from the traditional tympanometry, that you can get from 226 hertz or 1000 hertz or 680 hertz or 660 hertz tympanogram, and it also gives additional information. So how do we measure with the wideband tympanometry? So what the wideband tympanometry does is it gives, at different pressures, it measures the wideband absorbance. Like it gives at plus 200, it's measuring the absorbance. Then again, it goes as the pressures is sweep between plus 200 to minus 300. At every single pressure point, the wideband absorbance is measured. So if you look at it this way here, it gives you the 226 hertz measurement here. And then when you plot absorbance, so there's a lot of stuff, points in here, like there are about nearly 660 points, because at every pressure you get absorbance of curve there. So, but what you do is when you measure, Okay, so when you measure, we get this several points here, and when you with the adults, you average between 375 to 2000 hertz. You average the absorbance across the pressure from 375 to 2 kilohertz, and then you get one single absorbance curve. And at that absorbance, you measure what the wideband absorbance is across the whole range, and that is the wideband tympanogram. I'll show you in the next slide, which will be a bit more clear. So here, now this is the wideband absorbance tympanogram. So you average for adults, it's average between 375 to 2000 hertz. And in the infants, it's average between 800 to 2000 hertz. So you average these graphs here, and you get a wideband tympanogram. And the wideband tympanogram is again given in terms of absorbance there. So all this pressure points is given as one single pressure curve. At that peak absorbance, you measure what the wideband absorbance is across the whole frequency range. And that is your wideband absorbance at TPP. So when you average these absorbance here, and then you get the curve, and the mid-layer or the TPP is the one where the absorbance is the highest. So that's taken as the TPP. And at TPP, you draw the curve across the range, and that gives the wideband absorbance across the whole frequency range at TPP. So when you measure at wideband absorbance, you get two curves. One is measured the wideband ambient at ambient pressure, that is when there's no pressure, and then other one that is averaged at the TPP, or the peak tympanometric pressure. So you get two different curves. So this whole three-dimensional graph is collapsed into one two-dimensional curve. So when you measure the wideband tympanometry, you get these two curves, one that measured at ambient one, and then one measured at the peak tympanometric pressure. Apart from the wideband absorbance measure, you also get a lot of other information. For example, this is the 220 hertz, 226 hertz. It is measured under the standard tympanometry. You get the Y as well as B and G, and you get the measurement at resonant frequencies, and you get the wideband absorbance curve. So you do get your 226 hertz, the compliance, the volume, the mid-layer pressure at all these frequencies. So apart from the wideband absorbance, it gives a lot of other tympanometric measures as well. So it does both standard tympanometry as well as wideband absorbance measures at the same time. So this is again, and you can choose which of the frequencies you want the display to be, and then you can show what parameters you want to be displayed in the results. So in summary, wideband absorbance result, it gives you results across frequencies at various ear canal pressures. It provides tympanometry as well as provides additional information like phase angle and resonant frequencies. It provides a wideband absorbance result, which gives us an absorbance versus pressure, and also, I said, with the resonant frequency of the mid-layer as well. So that is wideband. That's a pressurized wideband absorbance or wideband tympanometry. Let's look at the other measure that we can do, which is wideband acoustic stapedial reflex. Now, in the wideband acoustic reflex, it is the probe tone, which is usually 226 hertz in the standard tympanometry. In case of wideband absorbance, it is the click signal is a probe tone, and the click is the same click signal as used in the wideband absorbance measurement. It has got frequencies between 250 to 8000 hertz. The activators are either tonal or total, that is 500, 1000, and 2000 hertz, or a broadband noise. And the reflex can be measured both either ipsilaterally or contralaterally. So with the reflex, the click is measured. So the click, say, is given, and then you measure the wideband absorbance. And then a pulsed activator is given, whether it's broadband or the tonal pulse activator, and that's followed by the click again, and then you measure the change in the absorbance. And each pulse has got 4 presentations of the activator and then the click. Each stimulus is presented twice at each level, and then there are 10 different levels, each in 5 dB step, going from 45 dB to 90 dB SPL. So for the wideband reflectance, so the acoustic reflex, the shift in the absorbance is expressed in terms of absorbed power level, which is given in terms of decibels. So when they measure the difference in the absorbance, it's measured relative to the initial click where there was no activator present. And the criteria for reflex is that the similar shift has to be seen across all the 4 pairs. And you can see like in 2 of the pairs and not in the other 2 pairs, then it's not considered as a reflex. It has to be consistently present across all the 4. And absorbed power level has to be greater than 0.7 dB. And you need to see the expected spectral shape, that is a drop in the absorbance compared to the regular absorbance. So I'll just show the example of how the acoustic reflex would look. So this is the absorbance of a change, and you can see by about 65 dB that you can start to see the drop in the absorbance. And you can see that as the intensity increases, the amount of absorbance also reduces there. And this is the significant level where a significant drop in the absorbance was observed. I haven't done much work on the wideband acoustic reflex, so I can just go by what is provided in the literature. I don't have much experience of working with wideband acoustic reflex. The wideband acoustic reflexes are supposed to be elicited at a much lower level compared to the standard reflexes. So it's at least about 12 dB more sensitive than 226 hertz. And it's a measured over a whole frequency range up to about the maximum frequency shift is below 2000 hertz. You don't see much change below about 2000 hertz. If I can just go back to the slide, you can see the most of the absorbance change is usually around up to 2000 hertz. So either you can go for overall, or you can just look at the whole spectral drop in case of the absorbance. So SR shift is measured across the frequency range, and a couple of studies have found that, like with certain percentage of people who even had an absent standard acoustic reflex had present wideband absorbance, probably because it can still be elicited at much lower level, and then it covers a whole frequency range. Okay, so that covers the normative aspect of the wideband absorbance. Let's look at some of the application of wideband absorbance in identifying mid-ear dysfunction. So to start with, I should say there's no one single curve that defines a normal pattern. So there are several variations present within a normal pattern. As long as the results are present within the normative range, then you can consider it being normal. Now you can see that some of the curves you can either have a 5 to 95% or 10 to 90% normative range. So the curve is given in both frequency ranges, the normative ranges. But you need to, rather than just compare it to any mean value, it's always better to compare across a normative range rather than just one mean pattern for normals. The other thing that you need to be careful is the probe fit. Sometimes if there's a loose probe fit, you can see that there's a lot of absorbance in the low frequencies. Usually about anything about 60% absorbance is considered abnormal in the low frequencies. On the other hand, if the probe is blocked, you can get absolutely no absorbance in there. So, and you may think, oh, like, this is an abnormal absorbance, but sometimes absolutely fully blocked probe can give very abnormal result as well. So make sure that the probe is not blocked, or it's relatively clean. Now, most of the work, the initial work was done with the infants. The concept of wideband absorbance was there for a few years. And with the introduction of newborn screening across the world, there was a need of a test that would differentiate the miliary status, because you get a lot of false positive results with because of the miliary dysfunction. And 1000 hertz tympanometry was not that effective, so they were tested to look for a bit more sophisticated ways of measurement of miliary function. And that's how the application of wideband absorbance started to become a bit more popular. And then it also moved to the other miliary disorders. But you can see a lot of work that has been done with the infants, the newborns, and then the young infants. Now, if you compare the infants that passed or referred newborn hearing screening, when you look at the 1000 hertz tympanometry, you see that with the infants that passed or referred with the ABR screening, you get similar results when you do 1000 hertz tympanometry. But on the same in infants, when we do the wideband absorbance measurement, you do see that the wideband absorbance in the infants who referred during the newborn screening have much lower absorbance compared to the infants who passed the newborn screening, especially in the mid-frequency range. So wideband absorbance was sort of showing difference in the infants who referred because of their miliary dysfunction. Now, whenever you look at a test or a diagnostic test to say how useful it is to identify any miliary pathologies, we usually do a test of area of, it's called AROC. So when you look at the AROC, area under the curve, so you can see that a diagonal line, you plot the sensitivity versus 1 minus specificity on the x-axis. So a diagonal line, that means it's 50% effective. So if you take 100 infants, so a diagonal line means that it can identify 50% of the time. So it's really not a useful test. So any test to be significant or to be useful, it has to show a higher AROC value. So any value it is about less than 0.7 is considered as less accurate, and anything up about 0.8 is acceptable, and anything greater than 0.9 is highly accurate. And with the newborn infants, when you compare the performance of the 1000 hertz tympanometry, you see that the area under the curve is 0.72. It's just about the 0.7 mark there. Whereas wideband reflectance at 1 kilohertz is 0.82, and if you take about 2 kilohertz, it's again 0.9. So it's a very highly accurate test compared to tympanometry. Now, these are some of the tests that have been done, like Sanford and Hunter. They were one of the earlier studies that have studied the absorbance in infants who passed or referred in a DP-OAE screening test. And the Sanford has given in terms of absorbance. This is when the absorbance is, this is the one with the infants who passed the newborn screening, whereas this one is the infants who referred in newborn screening. So you can see a huge difference in the absorbance, especially in the mid-frequency range, with the absorbance reduced in the infants with miliary pathology. The same thing with Hunter. You can see that the absorbance is reduced, or the reflectance is very high in the infants who referred in the screening compared to the infants who passed the newborn screening. So it's been pretty consistent across the results that the ES who refer have a very reduced absorbance compared to the infants that passed the newborn screening. Now, we compared different tests, like a different criteria, like the different pass and fail criteria. So when the infants passed or passed the newborn screening, irrespective of the test that you did, then the absorbance was all similar across all the different tests. But if you look at the criteria for refer, then you can see that the infant, if you take a high frequency tympanometry as your reference test and you compare the wideband absorbance, then you can see that they all have a normal, most of them have got a relatively normal absorbance pattern there. But as you make the reference standard testing criteria a bit more stricter, that is, if you include the high frequency TIMP and the TEOE or DPOE as your reference test, you see that the infants who refer in these tests, who do not pass these tests, have a much lower absorbance compared to the ones that have passed the absorbance. So you can see there's a huge difference between the infants who pass their newborn screening versus who refer in the newborn screening test there. So with this, you need at least a minimum of 2 tests to be a reference test to test the milieu function. So if you look at it this way, a combination of high frequency tympanometry and DPOE seems to be a good combination for us, a screening test. So what the tests have suggested is, in quite a few places, the OAE is used as a screening test. Not all the centers use a double ABR. So when you use a OAE alone, then the infants that that can sort of, who refer or pass, they can have different absorbance criteria. So the wideband absorbance can act as an adjunct test and can help to filter out the infants who could have a conductive pathology versus a sensory neural pathology. For example, if you do OAE as well as absorbance, and if the infant passes both the tests, then you can consider that the screening is passed, so you don't have to do any follow-up. But if an infant has got both reduced absorbance and reduced OAE, then you know that it probably, the possibility is because of the fluid. So you can review them again either the next day or after a couple of days. Usually infants, when you test them on day 1, they tend to have both low OAE and low absorbance. So when you test them a couple of days later, as their milieu effusion improves, their absorbance and then the OAE improves. So that's a reason for a review within a couple of days. And if they pass the OAE, but they have got reduced absorbance, it's probably because there's the probe could be blocked, or so there's a slight effusion, but the OAE is able to overcome that, and then you do get the normal OAE. Again, there's no need to rescreen because the infant has passed the OAE. The reason for concern is when they have a normal absorbance and then low OAE, then they should be prioritized for a diagnostic testing because they're likely to have normal milieu function, whereas the OAE shows that there could be something wrong with their hearing. So they should be prioritized for diagnostic testing. So this can be a useful test when you're using it as a screening test. So as an adjunct test, it's really helpful. So one of the applications of wideband absorbance is to identify milieu effusion in infants. So the infants who refer with the newborn screening most likely have a milieu effusion. That's because of the amniotic fluid or there's the fat deposit in their vernix in their ear canal, and that could be causing the drop in their absorbance. So they need to either review or prioritize for the diagnostic testing depending upon their OA results. Then we go to, I'll take you through different milieu pathologies, and the other one is the eustachian tube dysfunction. Now we know that usually when we say C-type tympanogram, it's associated with eustachian tube dysfunction. Now in this case, a comparison of the ambient and the pressurized absorbance becomes very important here. When you do ambient absorbance measurement, the absorbance is highly reduced below 1.5 kilohertz and then improves after 1.5 kilohertz. And when you pressurize the canal, so when you bring it to middle pressure and then measure at the middle pressure, you see that the absorbance has improved there. So when there's eustachian tube dysfunction and you pressurize the ear, and then when you equate it at the middle pressure, you measure the absorbance at the middle pressure, it shows improvement. So that's the one hallmark of eustachian tube dysfunction, is the improvement in absorbance at TPP compared to the ambient pressure. And this is a groups of measure. Like this is the people with normal middle function, and then a group of patients with eustachian tube dysfunction. You can see that their average absorbance has come down below 2 kilohertz, and then so it's improved in the 2 to 4 kilohertz range. Whereas when you measure the absorbance at middle pressure or TPP, you see that the absorbance has risen to normal levels. So if you compare the difference between the ambient and the the TPP absorbance, you see that as the difference between as the difference increases, as the middle pressure reduces, you can see that the difference also increases. That is, at lower middle pressure, that is minus 300 to 400 betacapascal, the difference between the ambient and TPP is higher compared to when the middle pressure is minus 100 to 200. So as the middle pressure drops, the difference between the ambient and the pressures conditions increase. So this is here again. So as the middle pressure reduces, you can see, like, this is the control group or the normal group within 0 to minus 100 middle pressure. And then as the middle pressure reduces, you can see the absorbance reduces. Now, when you equate at TPP and you measure the absorbance at TPP, you can see the absorbance is normal in all the 4 groups. So that was with the eustachian tube dysfunction. Now this is with in ears with otitis media with effusion. Now, when we look at any of the absorbance patterns, you need to look at across the whole range. Some of the pathologies are more prominent in the low frequency range, some in the mid frequencies, and so some in the high frequencies. So when you look at the pathologies, look at the spectrum and then see what the pattern is across the frequency range. So when you look at the middle ear effusion, you see that the absorbance is reduced, whether you do the ambient measurement or the pressure. So there's not much change between the 2 pressure conditions. So it is reduced under both conditions, and it's significantly lower compared to the normal middle ear, so normal absorbance, whether it's ambient or in the pressurized condition. So if you look at an example here, this is from the ear of a 2-year-old child with bilateral effusion. You can see that the effusion is much significantly reduced. And sometimes you tend to see a peak around 3 to 4 kilohertz in cases of ears with otitis media. Now, otitis media can vary a lot between the children. Like, and you can see the amount of effusion is different. Like, some can have slight effusion, some can have the whole ear cavity being filled with effusion, some can have thin effusion, some can have thick effusion. So the absorbance could actually change across the depending upon what's going on in the middle ear. So though the typical pattern is reduced absorbance with sometimes a peak at around 3 to 4 kilohertz, it's not all, the peak may not always be present, but the reduced absorbance across the frequency range is a hallmark of otitis media with effusion. Another complication of the middle ear condition is cholesteatoma. Now, cholesteatoma is a non-cancerous lesion of the middle ear, and it can be very devastating if it's not picked up earlier. It can erode the whole middle ear cavity and also the intracranial structures. So it can be a bit more in a debilitating condition. And before we don't have much results on the ears with cholesteatoma. We're just starting to get some sort of information. Some of the milia conditions are quite well sort of, studied with respect to wideband absorbance, like eustachian tube dysfunction or miliar effusion or autosclerosis. Whereas some of the other conditions, we just got have very few case studies, or it's just sort of, emerging. And we should remember that wideband absorbance is an emerging technology. We don't have answers to all the questions. We don't have like a definitive pattern for all the miliar disorders. It's just emerging, and probably in the next few years, we'll see a lot of literature coming about on different miliar pathologies. Some of them have got sort of, we do have very little results, and cholesteatoma is one of them. So if you look at cholesteatoma as a group, you can see that it's reduced in whether you do an ambient measurement or a TPP. But interestingly, the absorbance pattern tends to vary with whether it is an epitympanic lesion or it is a mesotympanic lesion. And again, like, whether it's epitympanic cholesteatoma or is it in the beginning stages as a retraction pocket. So in case of epitympanic, you tend to see that there's a bit of an improvement under T and pressurized condition, whereas if it's a mesotympanic lesion, there's not much difference between the two conditions. When I say epitympanic condition, it's about the head of the malleus, so it's more of the supra structures are involved, whereas the head of the malleus. Whereas mesotympanic lesion, usually the inferior stapedial joint and the stapes are involved. So you do tend to see that both the absorbance at ambient and tympanic peak pressure are reduced, whereas in the epitympanic, there's some improvement with the epitympanic cholesteatoma compared to the mesotympanic. As I said, we are still in the very early stages of differentiating these conditions. It's very exciting, but it's in the very early stages. Now, with tympanic membrane perforation, there are a couple of studies that have done some on modeling and some on cadaveric ears and some on case studies. The overall agreement is that absorbance varies with the size of perforation. The location of perforation doesn't affect the wideband absorbance. That is, whether it's an anterior perforation or a posterior perforation doesn't affect absorbance much, but whether it's a pinhole perforation or a small perforation or a large one affects the absorbance. So with the pinhole perforation, with the low frequencies are affected, and as the size of the perforation increases, the peak moves towards the high frequencies. You can see from a pinhole perforation to a small perforation to a larger perforation. Some people call it as a multi-peak pattern, and some say it moves towards the high frequencies. But you can see a gradual change in the absorbance as the perforation moves from a pinhole to a larger perforation. The other miliar disorder is the ossicular chain dysfunction. Now, this is a very typical pattern with ossicular chain dysfunction, is that you see an increased absorbance around the 0.6 to 0.8 kilohertz. This is because of the lax or the reduced stiffness of the miliar there. You see an increase in the absorbance and a peak around the 0.6 to 0.8 kilohertz. And this is an example of a patient with the ossicular chain discontinuity. Similarly, with grommet in situ, then again you see slightly, if the grommet is in situ and it's patent, then you see an increased absorbance around the 1 kilohertz. Again, some people, they call it as a multi, peaks and valleys, or multiple peak pattern, or there's once of increased absorbance at 1 kilohertz. That's usually if the grommet is patent and working fine. So you can see the patent grommet with an increased absorbance, which is similar to the ossicular chain discontinuity pattern there. Whereas on the contrary, if it's of a block grommet, so this is the patent grommet, and then if it's of Yeah, so this is a case of sort of, a grommet where the grommet sort of, is working fine, and like we got a grommet where it's sort of, blocked, but it's got a middle dysfunction sort of, behind it as well. So with a blocked grommet, if it's a normal middle function, you see that sort of, absorbance sort of, is improved, whereas with the if there's a abnormal middle function, you tend to see that the whole absorbance is reduced compared to a normal pattern. Heel tympanic membrane again. Heel tympanic membrane perforation has increased absorbance again at around the low frequencies. So whether it's ossicular chain dysfunctionality or tympanic membrane perforation, that is heel, gives an increased absorbance at about 1 kilohertz. But the difference is that you can also see that the resonant frequency is relatively normal with the heel perforation, whereas it is reduced in case of ossicular chain discontinuity. Another one that is studied well is autosclerosis, and Shanaz, who will be presenting in 2 weeks' time, he's done a lot of work on wideband absorbance in ears with autosclerosis. And the most prominent drop with ears with autosclerosis is because of the increased stiffness. You see that the drop in absorbance is it's between 0.7 and 1 kilohertz range. Usually it's 1 kilohertz, and 500 hertz has given a very high performance in terms of identifying autosclerosis. But across the studies, reduced absorbance at 0.7 to 1 kilohertz is a more sensitive range to identify autosclerosis. This is again studies of of a group of patients who show reduced absorbance below the 800 hertz range. This is another example, and again, autosclerosis, it's not a stable condition. So it can progress over a period of time, and then the autosclerosis, the wideband absorbance pattern depends upon the stage of autosclerosis. Like whether it's in the early stages or it's in the very advanced stages, the absorbance can change over a period of time. With Meniere's disease, we don't have many studies on Meniere's disease. Now, because the Meniere's disease is more of an inner ear condition, there's no mass or stiffness changes to the middle ear per se, but then it could be because of the friction of the conductor component that can affect the middle ear status, but we don't have that many studies to describe the wideband absorbance in ears with Meniere's disease. This is on a sample of subjects that we have studied Meniere's disease, the wideband absorbance in Meniere's disease. We found them to be slightly higher compared to the mean values to be slightly higher compared to the normal values, but they're still within the normal range. As I said, we don't have much results with the ears with Meniere's disease, or for that matter, with results with most of the inner ear conditions. One of the conditions, again, is the superior canal dehiscence, which gives A-type tympanogram when you do the middle ear assessment. And there are 1 or 2 studies and that have said that there is a peak, it's reduced across the frequency range, but there's an increased frequency around the 1 kilohertz in ears with superior canal dehiscence. As I said, the very scant research, and it's just starting to emerge. But 1 kilo increase around 1 kilohertz is supposed to be a feature of the superior semicanal dehiscence. Like this is the, I'm just comparing it with the OME and superior canal dehiscence because both of them show a reduced absorbance pattern, whereas superior canal dehiscence shows increased absorbance around the 1 kilohertz, whereas the OME doesn't. There's only one study that has compared wideband absorbance in ears with LVAS, and they have shown that the ears with LVAS have reduced absorbance around up to about 1.5 kilohertz. As you can see here, the LVAS group has reduced, it's still closer to the 10th percentile range, but if you compare to the mean values, it is reduced. And as I said, this is the only study that has been done so far with wideband absorbance in ears with LVAS, but it is showing a reduced absorbance. So the middle conditions show some sort of wideband absorbance results, but it's still not very it's not very well studied, I should say. So in summary, some of the middle conditions show certain patterns that we can apply on. So a normal one, ears do have a normal absorbance at ambient and TPP condition across the whole range. In eustachian tube dysfunction, the absorbance at ambient condition is reduced, but at TPP it comes back to normal. Otitis media, it's reduced across the whole range with a probable peak around 3 to 4 kilohertz. And with tympanic membrane perforation, it varies with the size of perforation. So with pinhole perforation, a very small perforation, it is high below 1 kilohertz and moves towards the high frequencies as the size of the perforation increases. In otosclerosis, it is reduced in the low frequencies, mainly below 1.25 kilohertz. With cholesteatoma, again, it's mainly reduced across the whole range, and there's no difference whether you pressurize or not. The retraction pocket is a condition which is a precursor to the cholesteatoma. So there's retraction of the part of a tympanic membrane, and it's of as it goes towards the middle ear, it can collect some debris and then form the mass. So the retraction pocket is the very early stage of cholesteatoma. And in case of epitympanic retraction pocket, you can see an improvement in under TPP condition, whereas in mesotympanic retraction pocket, you don't see much of a difference. It's very, it's an important diagnostic one, especially for ENT consultations, where epitympanic retraction pocket can be a bit of a tricky one to diagnose. You have to have CT and MRI investigations to do that. So this is showing some sort of very preliminary interesting results. And superior canal dehiscence, as I said, like a small, it's reduced across the whole range with a probable small peak around the 1 kilohertz. So wideband absorbance, we know that it can give different patterns depending upon the different middle pathologies. So we'll look at just a couple of examples of how it can improve the diagnostics of accuracy. So if you look at ears with and without effusion. Now, a C-type tympanogram can mean eustachian tube dysfunction, but that can occur with or without fluid. So you get a C-type tympanogram and you get a normal absorbance pattern when you pressurize it. You can be sure that there's no middle effusion there. On the other hand, you get a C-type tympanogram and then you do ambient and then pressurized tympanogram, and you don't see much difference between the two, or the pressurized tympanogram doesn't absorbance doesn't improve to a normal level, then that's a suggestive of effusion in the middle ear. So a ear with effusion doesn't show a huge improvement with the pressurization of the ear canal. This is an example. Both the ears show a negative middle ear pressure, and this ear is the one without any effusion. So you pressurize the ear and then it improves back to normal level. And then there's another ear where you pressurize and it's still not back up to the normal level. So you know this ear has got effusion and this ear doesn't have the effusion. So it helps to differentiate between ears with effusion or without effusion. If you look at the difference between the ears with effusion, with normal, there's not a big difference between the two conditions, that is ambient and pressurized. Whereas in OME, again, there's not a huge difference. Whereas ears with eustachian tube dysfunction show a big difference between the two pressure conditions with an improved absorbance at the tympanometric peak pressure. Now, there's another implication for that one. So if you look at the eustachian tube function, so this is the comparison of eustachian tube function, the wideband absorbance in ears with the eustachian tube dysfunction. So when you compare with normal, as the middle ear pressure reduces, with from -100 to -200 to -300, the wideband absorbance also reduces. That means the energy absorbed by the middle ear is reduced. But when you equate it at the tympanic media pressure and then you measure the absorbance, then it's normal. So at the same time, we can measure a pressurized OAE as well. That is, we can pressurize the ear canal to the TPP and at the same time measure the autoacoustic emission. We can see that as the absorbance improves, with the TOAE, there are two things that we measure for a pass or fail criteria. One is the SNR level, the SNR ratio, the signal to noise ratio, and the TOE levels. You can see that with the drop in the middle ear pressure, the SNR also is reduced. When you equate them at middle ear pressure, you see that the SNR improves. So the signal to noise ratio has improved as the middle ear canal is pressurized. Similarly, you can see that the TOE level is reduced as the middle ear pressure drops. But when you improve it to when you measure the TOE at the TPP, then you can see that it has improved. It's still less when compared to the -300 to 400, but it's a huge improvement compared to when you measure at ambient pressure level. So what does that mean? So if you measure TOAE at whether it's at a ambient or a pressurized level, it doesn't make a huge difference when the middle ear is functioning normally. Whereas when you compare the OAE function between ambient and the pressurized condition, you can see that as the TOE level and the SNR improves, the TOE pass level also improve. Okay, you can see here, especially it's very prominent in the between -100 to -300 decapascal. Not a huge difference in the -300 to 400. So the improvement in the pass rate was nearly 17.8% with middle ear pressure of -100 to 200. And with -200 to 300, there was nearly 30% improvement in the pass result. So which means that you get a child and then you suspect a eustachian tube dysfunction, C-type tympanogram, and you do OAE, and then the child doesn't pass. Let's take an example here. So this is the child. It's got a slight of conductive component in there, and then you measure TOAE at ambient pressure, and the OAE the child has not passed the OAE, and because it's not present across all the whole frequency range here. And then you pressurize the ear canal, and then when you measure at TPP, you can see that the TOAE is also normal. So what that means is when you get a child with a C-type and you do a pressurized TOAE, you don't have to get the child back to assess the hearing function later on because you know that the TOAE is normal there. So it reduces your follow-up rate because of the failed TOE. As I said in the previous slide, you see about 30% improvement when the middle ear pressure is between -200 to 300 and closer to about 20% when it's between -100 to 200. So this is an implication because the OAE has improved because the energy that's absorbed in the middle ear has also improved. This is just an observation that we did, that with the OME, when there's effusion in the middle ear, you can still get an A-type tympanogram, depending upon what the fluid level is and how thick the fluid is. You can still get an A, B, and C-type tympanogram. So we compared whether there's any difference between the three types of tympanograms, and we found interestingly that the absorbance changed depending upon the kind of tympanogram. So in the B type, there was not a big change at all. It was reduced whether we did a pressurized or a non-pressurized one. It was still much reduced. In the C type, there was some improvement, but still it was not within normal level because there's still effusion in there. And in the A type tympanogram, we could see improved absorbance at the TPP level. So that was interesting to see that though there was effusion, the absorbance pattern was quite varied according to the type of tympanogram as well. There's not many studies that have observed the audiological findings with related to the fluid viscosity. And when we compared the fluid viscosity, whether it was a serous effusion or a glue ear, we found that ears with effusion, serous effusion showed slight improvement with the pressurized one, whereas with the glue ears did not show much improvement. There are not many studies that have done, so we don't know what the factors that that influence, or how it's influencing. In terms of management, probably it may have some sort of implication. That is sort of if there is thick effusion, they are prioritized for sort of surgery, whereas if it's an older children, if it's a thin effusion or a serious effusion, probably we can wait and watch. So that's the only implication. There's not many studies that I could find about the viscosity of effusion and then the audiological results. So I'm just going to give a couple of examples before I stop here. So this was a child with OME, and then he had A-type tympanogram. But when you look at a wideband tympanogram, it was a flat type, and then the effusion is there. So if you get this sort of type of flat absorbance pattern, you know that there's a middle ear, there's sort of an abnormality of the middle ear, and then definitely it's sort of the pattern is more likely suggestive of the Otitis Media there. So it can act as a good cross-checking test. When I'm describing all these results, I'm not taking wideband absorbance in isolation. So this is actually, it shows improved performance compared to tympanogram, but still it is just one of the tests in your whole test battery. You need to compare it with the other tests, with the case history and the other observations. Just do not depend upon only on the wideband absorbance. We are still not at that stage yet. And this is another reason, area where it is interesting is that when there's epitympanic retraction pocket, which later on develops into cholesteatoma. So when do we, the question for the surgeon is, when do we operate, or when do we sort of wait and see? So with the epitympanic retraction pocket, in order to differentiate with cholesteatoma, most often the measurement is, the criteria is they send it for CT and the other investigation to rule out the cholesteatoma with retraction pocket. So we are looking at seeing if wideband absorbance can be a reliable measure of suggesting retraction pocket versus cholesteatoma. And the very, very preliminary results show that yes, sort of, the wideband absorbance has a promise in identifying the retraction pocket and differentiating it from cholesteatoma. So with retraction pocket, there's no, there's a negative pressure in the retraction pocket, and then when you pressurize it, it comes back to normal at TPP. Whereas in the cholesteatoma, there's the mass that is sitting in there, and that's why it doesn't come back to normal levels at TPP. So that's a good indication that there's, whether it's a retraction pocket or cholesteatoma. And as I said again, it's very early results. Now, when we say middle ear retraction, it can mean a lot of stuff, different kinds of retraction. Like we can have a eustachian tube dysfunction, which is a generalized retraction of the middle ear, whereas the eardrum can have pockets of retraction. It can have in the attic region or in the mesotympanic region. And that is a very different pattern compared to a eustachian tube dysfunction. Now, the attic and the mesotympanic retraction, these are pockets are the one that they can be a bit more precursor for cholesteatoma. So they need to be differentiated from a eustachian tube dysfunction. You may get a C-type tympanogram, and this is what helps you in differentiating whether it's a eustachian tube dysfunction or something more sinister that's going on in the middle ear. Now, with the tympanogram, one of the limitation is that when there are multiple pathologies, you won't be able to identify between based upon the tympanogram pattern, whereas wideband absorbance can throw some light if there are multiple pathologies. For example, in this case, we had a 12-year-old boy who had a history of previous unsuccessful meringoplasty. He had a bilateral perforation and a chronic discharge. and his audiogram showed a B type with a conductive hearing loss. But you know that, like, you know, if there's a perforation, it doesn't reduce the absorbance so significantly across the whole frequency range. And this kid went on to have further investigations, and he had a mesotympanic cholesteatoma and then with the ossicular chain dysfunction. So if there's a perforation, a B-type tympanogram would give a flat-type tympanogram with a large cavity volume, and you get a conductive loss, whereas a wideband absorbance can sort of say it's not only a perforation, there can be something sinister going on behind the eardrum. So when there's multiple pathologies, it's sort of, helpful to use it as another additional tool. This is another child with a mild conductive hearing loss. He had a A-type tympanogram, but still it's not a fully normal looking A-type tympanogram, though there's a peak there, but then you can see it's got a bit of an abnormal negative tail there. And if it's a normal A-type tympanogram, you should not see such a big drop in the high frequency range. And this child was a young child who was referred from a GP or a general practitioner, and they thought there was something wrong that didn't look normal. They thought something was poking from the middle ear, from the tympanic membrane, and the GP thought the child is a bit too young to have cholesteatoma, but in the end, the child did have congenital cholesteatoma. So just a A-type tympanogram, but then having a reduced absorbance can point out that there's something else that could be going on in the middle ear. Similarly, like, you know, just having like, for example, with this one, this patient had a C-type tympanogram. So if you look at the tympanogram alone, it is a negatives of, you know, -203. So there's a eustachian tube dysfunction. And then when you do the absorbance, yes, there is a improved absorbance. There is a eustachian tube dysfunction, but there's a hugely reduced absorbance in the other frequencies beyond 1.5 kilohertz. And further investigations were done with this patient who had mesotympanic cholesteatoma along with eustachian tube dysfunction. So so when you get a C-type TIM, so C-type TIM always doesn't mean just eustachian tube dysfunction alone. So if there's multiple pathologies, so this was a way that, you know, we could identify there was something else that was going on along with the eustachian tube dysfunction. Another thing that wideband absorbance is helpful is to look through the grommet or perforations. So if there is, this child had a grommet, so a grommet in situ, and then you see that the wideband absorbance is the normal, they're showing the double peak pattern with an increased absorbance around in the low frequency range. So though through the grommet, you can see that the milieu function is normal, whereas in another example that we had, this child is the one, like, you know, who had a reduced absorbance here, and then the grommet was blocked here, and then they had a milieu dysfunction. Whereas this child had blocked grommet, but the milieu function was normal. So whether it's blocked, you know whether the milieu function is normal, or there could be sort of a possibility of fluid buildup again behind the blocked grommet. So though both have a B-type tympanogram, you can see whether there's a milieu function is normal or not through the grommet. Again, so with the perforation, so like this patient had a perforation, and but with the wideband absorbance, and then you could see that, like, there was perforation, and there was a ossicular, there was a perforation, and then there was the intact ossicular chain, whereas in this case there was there was an ossicular chain abnormality as well. So sometimes we don't get a single a standard pattern when there are multiple pathologies, but then if there's not indicative of any one particular dominant pattern, then you can suspect there could be something else that's going on with the milieu pathologies. There's another study that compared wideband absorbance in ears with otosclerosis, semicircular canal dehiscence, and ossicular chain dysfunction. Now, we know that all the three conditions give a A-type tympanogram, and in this condition, the absorbance, the way it has been represented is the absorbance in terms of absorbance level in terms of dB, and then this is the difference compared to a normal level in ears with the 3 different conditions. And you can see that wideband absorbance shows 3 distinct patterns across the 3 different pathologies. So wideband absorbance certainly has a promise to differentiate the middle pathologies. And then the same patterns of what we found as well. So otosclerosis has reduced wideband absorbance. Semicircular canal again has reduced, but around a peak around 1 kilohertz, whereas with ossicular chain discontinuity, it shows a peak in the low frequencies around 800 to 1000 hertz. So there could be other potential uses of wideband absorbance. For example, resonant frequency. It can help in differentiating ossicular chain dysfunction versus heel tympanogram, or tympanic membrane perforation. It's also suggested that as the otosclerosis progress, resonant frequency could be one of the measures to study the progression of the disease as well. So the resonant frequency could increase as a disease progresses. They're not actually, there are not many studies that have done, but these are all potential uses that could be used in either monitoring the ears or help in differentiating between the ear conditions. We can help with monitoring of the retraction pockets and to guide the surgeons of when there's changes in the miliar changes. So because as I said, retraction pocket can be a precursor for cholesteatoma. So when we monitor a person over time, they don't have to go through the CT, and then we can have a series of wideband absorbance and then guide the surgeons. That is another possible application. That's a future application that's that has got a very interesting application. Or determination of eustachian tube function for patients for laryngoplasty surgeries or retraction pocket as well. So if there is a good improvement under pressurized condition, that means that they have got a better prognosis. So there are the possibilities of using the wideband absorbance in clinical setup. So in summary, the advantages of measuring wideband absorbance is that it's a fast and invasive test and provides information across a wide range of frequencies, not just at one particular frequencies. It can be conducted at ambient or pressurized condition. So which means that because it can be done under ambient pressure, we can do it immediately after surgery. So there's really no harm in doing that because we can do OAE as well as the ambient pressure measurement. It has shown that it's more sensitive for middle conditions, and it can identify certain middle pathologies better than the tympanometry. As I said earlier, not all the middle pathologies have been studied extensively, but with some of the middle conditions that have been studied, it has shown better promise compared to tympanometry. It is less susceptible to myogenic noise because it measures multiple frequencies and it's a bit more robust, so it's very quick as well. And it's quite helpful in pre and post operative monitoring and useful for studying the progression of middle pathologies. Having said that, wideband absorbance is not, it's not the best sort of, it has got some of the drawbacks as well. But in the recent versions, there have been improvements compared to the previous versions, but it's still, I think there's a bit more sort of, work that could be done. We found that it's because it's not like a tympanometer, it's not a standalone equipment. So at this stage, I think it can be an additional test, but you can't just rely only on the wideband absorbance as the only equipment in your clinic. What we found was the saving of the file is not very user friendly. That is, you can't do the test and then save it quite well. You have to make a folder and then store the results. But if you forget to do that and then you do the next patient, so the whole list builds up and there's no file, there's a patient name attached to the file name. So you'll have to be a bit more careful, and it's not that user-friendly compared to saving the other test files. So it gets better with your practice, but it's not the quick or easy way to do that. Earlier, we used to find that with young infants, you can do wideband absorbance measure quite well, but when you do tympanometry, it can, with infants, the ear canal can collapse quite easily with negative media pressure. So with very young infants, it can be a bit tricky to do a pressurized tympanogram, whereas the ambient absorbance is much easier. Earlier with the earlier versions, when there's a tympanic membrane perforation, it was not very reliable, but I heard that the recent version is a bit more improved one. So in summary, wideband absorbance provides some information about mid-ear condition and provides additional information compared to tympanometry. Always use the normative range or a percentile. Just using group means will not give you an accurate picture of the mid-ear condition. With some of the mid-ear conditions, it's very good to compare both the ambient and the pressurized condition. But if you're using the Titan, it gives both the measures, and it's always good to compare both of them. And also remember that wideband absorbance is always related, so it can be influenced by the stage of the mid-ear disease. So advanced stage can have a different pattern compared to an early stage. And it can also give you more information when there are multiple mid-ear conditions as compared to tympanometry, where you cannot interpret the tympanogram based upon the when there are multiple pathologies. So use absorbance measurements as one of the assessment tool, but you need to interpret the results along with other test results and case history, and it should be just a part of a test battery and not just only the test. And use all the other measures. Acoustic reflexes are not easily available with all the clinical tests. You do need special a license to do the acoustic reflex testing, but pressurized and then ambient measures are easily available, as well as the tympanometry with the individual frequencies as well. Don't use the absorbance at ambient or TPP in isolation. It's always better to compare both of them together. And pay attention to the pattern of results across the entire range, and just don't take the mean value and say whether it's normal or not. So look at the pattern of results across a range. And again, be wary of the normal variations, and always remember when you're seeing the infants and young children to have the age appropriate norms. And thank you very much for listening.
Thank you so much, ma'am. Sorry. Thank you so much, ma'am, for such a comprehensive talk. And you've covered a lot of excellent clinical information in your talk. I'm sure a lot of audiologists will be listening, experienced as well as those who are learning audiology will have immense benefit from this talk. We'll open the round for questions now. Srividya, ma'am, do you want to start the questions?
Yeah, and just before, I just need to mention, with this presentation, I did the presentation. So this presentation was done in our department, and then both Venkatesh and I are equally involved, but I was just presenting the results on behalf of both today. Yeah, and you can, so you can open it for the questions now.
Ma'am, we have array of questions around. Already we have around 35 questions. How I'll compensate for time. It is 4:45 and I have the webinar till 5 o'clock. I'll quickly ask you questions as much as possible, please.
Yeah, sure.
Can you please answer? Yeah. Are the wideband tympanograms compensated or uncompensated?
Sorry?
Are the wideband tympanograms compensated or uncompensated?
Yeah, there's no pressurization of the ear canal with the pressurized tympanometry. You mean to say? Is the wideband tympanometry?
Yeah. Yes. Do you do a compensation and
Yeah, but
there is.
Ma'am, you can hear me?
Yeah, as said, no air canal volume is taken into consideration. It's like an uncompensated tympanogram.
What about the phase? You compensate with phase?
when you give the reflectance, it's a measure. You can measure them separately. Like you can measure the phase separately, and there are two ways of giving the phase. Now, phase, like if you take as a phase angle, yes, you can present them as phase. But there's also another way of presenting these days is what is called as a group delay, which you say in terms of in a time scale. So, like, the similar phase information can be also given as a group delay. So the reflectance is a combination of admittance as well as the phase.
Okay.
So it calculates the reflectance. It calculates the reflectance and the phase, and then calculates the admittance based upon that.
Okay.
So there's no yeah.
Okay, ma'am, can I go to the next question?
Yeah.
Hello.
Yeah.
Hello.
Yeah, sure. Hello. Yep. Hello.
You're audible, Srividya. Go ahead.
I think Srividya ma'am's internet is dropping down, so I'll continue with the question.
So I just, ma'am, next question.
I'll continue with it if your internet is dropping.
Hello. Yeah, why and what is the? Yeah, Imran, you take over the questions. Yeah.
Yes, ma'am. Yes, ma'am. Can you hear me, Sreedevi ma'am?
Oh yeah, sure, we can.
Okay. So the next question is why and what is the clinical importance of wideband absorbance, and is it necessary to include this in the current audiological test battery? I think you've already covered this quite comprehensively, ma'am. But you can correct me if I'm wrong. I think you are saying that we should not replace it with any test, but we should just include everything but add this as a part of the test battery.
Yes, like if you do wideband absorbance, it gives you information of whatever a standard tympanometer does and additional wideband absorbance measurements. But as a clinical tool to buy the wideband absorbance equipment, I would say sort of, you need to see what additional information you need to give, whether are you assisting with the medical management of the patient, or what is your purpose of testing? Is it if it's for diagnostic testing of the miliary condition, yes, it gives a lot of additional information. But as I said, we know a lot about some miliary pathologies, but not about all the miliary pathologies. So while it is a good clinical test, I say it's still a developing technology. So probably in the coming years, we'll have more information about the other miliary conditions, and probably then it's time to replace the tympanometer. But at this stage, we can use it as an adjunct test.
Yes, ma'am. And ma'am, the next question is, will clicks really create an impact on tonal frequency response in wideband reflexometry?
Sorry, can you repeat the question again, Imran?
Yes, ma'am. The question is, will clicks really create an impact on tonal frequency responses in wideband reflexometry? So what they're saying is that because we are giving clicks and the activator together, I guess they wanted to ask if there's any interaction between them, and if there is, how will it impact the wideband reflexes?
from my understanding, they're not given simultaneously. Like the activator is given, there's a slight, a few microseconds delay, and after that the click is presented. So there's no interaction between the activator and the clicks stimuli.
Yes.
So there's no impact on the by the activator on the absorbance level. No.
Can I add on? I'm Vanaja here.
Yes, yeah.
Yes, Sri, it was an excellent presentation and
Thank you.
good clinical implications highlighted. This part of it, I don't know what really they meant by the question, but then even when you're doing the normal reflexes, there is a slight gap between the probe tone and when the stimulus is presented, but still we say there are artifacts which can add up. Probably what happens here is it may add up or it may distort only at that one particular frequency. If I'm using 1000 Hertz for eliciting reflexes, only 1000 Hertz absorbance gets slightly affected, but the other frequencies still give us the information. So we have an advantage here is what I would think. Yeah, that was my thoughts, not really with any experience or anything.
Yeah, as I said, I have not worked with the wideband acoustic reflexes as much, so my experience with that is quite limited.
Srividya ma'am, do we have any time for more questions?
Sorry?
No, I'm sorry. Sorry, ma'am. I was just asking Srividya to wrap up the thing, or can we ask a few more questions?
Can I ask a question?
Okay, go ahead, Vanaja.
For sure.
Sreedevi, you talked of the normative data saying that till 5 years of age, there is the normatives keep changing, and only by 7 years of age, they are like adult type. So if we have to have a normative range in children, so like what age range do we have? Like should we have it for every month or what? 3 months, 3 years? Like what is your recommendation from based on whatever studies you have done?
When you look at the equipment, it has built-in normative range. So you can select the age ranges in that. So it gives you the 5th to 95th or 10th to 9th percentile. But if you want, you can develop your own normative data. But it's already inbuilt into the equipment as well.
Okay, so we don't have. But it also talked of different races, and there are studies of different races. The norms are slightly different. Is it clinically significant, that part of it?
The ethnicity, did you say, Vanaja?
Yeah.
No, we found it was not. It's not clinically significant.
Clinically significant. Okay.
But as I said, like there's one study that has done otosclerosis, and then they said when they had Chinese versus Caucasians, they did find that when they used the ethnic specific norms, then the test performance improved to identify otosclerosis. But then that was one study. We don't have many studies, but as of now, it's clinically not that significant to use ethnic specific norms.
I have a question, Sridevi.
Yes,
totally enjoyed your presentation. Just the grommet, even if the grommet is blocked, how can you assess the in middle ear function?
Yeah,
I mean the absorb.
When you do TIMP, you may get a B-type tympanogram with a 220 Hertz tympanogram. When you do absorbance, it shows a normal absorbance pattern.
Oh, so, okay.
That is the way you can say it is. And again, we do the absorbance at the middle ear pressure and at the ambient pressure. So it shows all normal.
Yeah. So Madhuri, to answer your question again, like depending, irrespective of what happens at the grommet, like still the middle ear structures do have some, they do absorb some energy and then they do reflect part of the energy. So even whether the grommet is blocked or not, still we can measure what's happening, so in terms of reflectance.
Yeah, that's really interesting, that part.
Because what happens at the middle ear is, you can have a reflectance that is a composite of what's happening with the difference of inner structures. So whether the grommet is blocked or not, still those structures do contribute to the absorbance or the reflectance. So that's why even in tympanic membrane perforation, you can still measure the absorbance.
No, in the yeah.
And in addition to Madhuri, you might have observed even with the blocked grommet, sometimes we get A-type tympanogram.
Oh, I haven't. Yeah,
we do video otoscopy. The grommet is blocked.
Sometimes, yes.
A-type tympanogram. That does indicates that it's just a grommet block and the middle ear is normal.
Yeah.
In absorbance, you get a normal absorbance pattern in the presence of blocked grommet. Then you can assume that the middle ear transmission is good.
Oh, yeah. It was giving it gives frequency wise. It reminded me of all those virtual instruments, all those stacked tympanograms, no? Look like.
Yeah.
Okay.
It is useful in a sense. If somebody using using a lot of multi-frequency tympanometry or a multi-component tympanometry, then this test becomes very useful, because with the one wideband tympanometry, we can extract 226, 660, 800 or a multi-frequency tympanogram with the different components B, G, and Y. So you don't have to repeat the test again and again, but these are derived from the click stimulus. They're not a direct measure as you measure in the other tympanometer. So in that way, in that way, it is very useful. So in one go, with a shorter time, you can analyze separately with all these results. So that is an advantage having the wideband tympanometry, but it's all derived from the wideband signal, not a direct measure.
It sounds very exciting.
Yeah, in that sense, it's an exciting. Yeah, you can classify the multi-component extraction to Van Heu's model and say whether it's good or not, normal or not normal, or following the pattern or not. And again, it gives the middle ear resonance directly measured. So another thing observed, the middle ear resonance measured through the wideband is more accurate than the one we use in GSA TIMSTAR.
Yeah.
Because TIMSTAR goes in a step of 50 Hertz cycle, whereas wideband gives an exact frequency. So there may be a slight in normative range.
Yeah. That can remove. Sorry, continue.
Sorry, ma'am. There's just about 3 minutes left before we need to wrap up the webinar because of the time duration limitation. Any questions from the panelists before we wrap up? If there are no questions, ma'am, just on behalf of some of the audiologists, I may just ask you, you did mention that whilst low frequency tympanometry detects more proximal pathology, whereas wideband absorbance deals with more distal pathology. So we were talking like last webinar and even before that about a combination of two middle ear pathologies, like for example a flaccid eardrum and an otosclerosis. So where 220 Hz will always detect the proximal pathology. Are you saying that if somebody has a flaccid eardrum and otosclerosis, a wideband absorbance will actually pick up the otosclerosis?
Yes, I think that's what I understood.
Theoretically, yes. But then, but it is a very interesting combination to being one being opposite. There can be otosclerosis, and then there can be let's say a flaccid tympanic membrane. we may get, I'm not too sure what kind of patterns of intake, because they both are opposing ones. And technically, yes, we should see a difference around the 1 kilohertz mark, but I'm really don't have any patterns of, with such pathologies. Theoretically, yes, it should be able to pick up both the autosclerosis and then the flaccid tympanic membrane. So probably like you will get a reduced absorbance around up to 1.25 kilohertz, but with one sharp peak around 1 kilohertz. So that's the pattern you would expect if there's combination of autosclerosis and the flaccid tympanic membrane. And then again, the resonant frequency will be higher because your flaccid tympanic membrane could be because of the healed tympanic membrane perforation. In that case, the resonant frequency will be higher. So it's just on the absorbance alone. So probably you need to look at the other wideband absorbance measures as well, rather than just only the absorbance. And as I said, absorbance is the one that is studied the most. But then these days there are other measures, like the group delay is starting to take quite importance in identifying the middle pathologies. So probably we need to look at the importance of the other wideband absorbance measure, so immittance measures, other than just the absorbance alone in identifying these pathologies.
Sure, ma'am. I've just got a good message from Srividya, ma'am, that there's another 15 minutes left. So we do have some span for questions. If that is okay, Sridevi, ma'am, can I continue with the questions?
Yeah, that's fine. That's fine.
The next question, ma'am, is about the Titan audiometer that you mentioned. They're asking, what do you mean by surface at peak pressure and ambient pressure, which is seen in the Titan wideband tympanometry equipment, and it's usually seen in only 1 by 24th octaves. What's the use of that value in middle ear assessment?
Okay. When we say Titan, like Titan, the two companies, and Titan provides provision for both ambient and then the pressurized absorbance. Whereas Mimosa, you can do the absorbance at ambient pressure only. So at ambient pressure, it's like doing autoacoustic emissions. You keep a probe and then you give the click and measure the energy absorbed. Whereas in pressurized absorbance, you pressurize the ear canal and as well as measure the absorbance. Now, the absorbance is usually given in 1/24th of an octave, which means it gives you a lot of different points and gives a bit more finer description of the absorbance at individual frequency. We don't need that kind of a finer analysis to do the measurements. Usually in most of the clinical studies, 1/3 octave is more than sufficient for clinical purpose, whereas 1/24th gives you a much more finer, so you get a lot more points for analysis, which if you're looking at measuring the significance of difference, you get about say 60 different points, which is hard to compare. Whereas when you measure at 1/3 octaves, then you get about 16 points. So it's much easier to manage and compare the different points. And at the same time, I should say, when you look at the normative, there are different ways of analyzing it. One is having a look at the normative range. Some researchers also talk about frequency ranges. That is, you divide the frequencies into low frequency, mid, and the high frequencies and compare the absorbance in those frequencies. And some researchers say the frequency band that includes 1 and 2 kilohertz is the most important for identifying the middle pathologies. So when you use the 1/3 octave, it's much easier to manage these comparisons compared to 1/24th. But you can get the absorbance across the different octaves. But most often the results are present as 1/3 octave.
Yes, ma'am.
Does it answer the question?
Yes, ma'am. I think it was very comprehensively answered. Ma'am, the next question is regarding the cases of autosclerosis, where sometimes we see the notch at the bone conduction, the Carhart's notch. So you showed us some wideband absorbance patterns for autosclerosis versus normal. So does the Carhart's notch, get reflected in the wideband absorbance patterns? Could you explain that a bit?
Carhart notch comes around the 2 kilohertz, around the 2 to 4 kilohertz range. Whereas with the wideband absorbance, the absorbance is reduced around below 1 to 1.25 kilohertz. So it's because the stiffness of the stapes increases, the energy that's reflected is in the very low frequencies. So that doesn't relate to the Carhart's notch. So the energy reflected is not reflected of the threshold. Like the earlier studies, they tried to correlate the energy that's reflected to the threshold. That's where the transmittance comes. But these days, no studies compares the absorbance directly to the threshold values as such.
Yeah, that's a good question, Imran. I don't think we correlated the Carhart notch with the atherosclerosis. The Carhart notch at 4 kilohertz, you see in not only in atherosclerosis, any mid-ear dysfunction, you can get it. So even with the glue ear, you can get it. So it's an indication that there's a problem in the mid-ear, and the mid-ear mechanical structure is dysfunction. So it's not exclusively to a atherosclerosis, but we see more often in atherosclerosis. I hope it answers the question, I suppose.
Yes, sir. Thank you so much. There doesn't seem to be any more questions regarding that. I mean, there are a few questions, but if that's okay, I will send it to you on your email. And if you have some time, you can answer it for the benefit of our listeners. But I think you have comprehensively covered mostly all in the questions that are previously answered. But there are some that may not have been covered, and I will send those questions to you. And if you could answer that, that will be great.
Yes,
questions from the panelists? Any comments from the panelists before we wrap up?
Like I already said, an excellent presentation by Aithal and it really highlighted the clinical implications. So I'm sure all clinicians are waiting to see when they can really upgrade their systems. But as a clinician, what people would really look into is, can this replace the older one? Because how many tests can we go on adding is what the clinicians most often ask me. It's a different thing in academic setup to say, I do 226 Hz tympanometry, I do multi-frequency tympanometry, and I do wideband absorbance. But in a clinical setup, doing all three becomes difficult is what most of the time what I hear. So maybe they'll wait for a time when we say wideband absorbance can replace 226 Hz tympanometry or multi-component tympanometry, then all clinicians will start using it, is the way I look at it.
But thanks, Vanaja. But I think the one advantage is that it can do the OAEs as well. So that gives a big the advantage to the equipment.
And the biggest advantage I liked in your highlights is the multiple pathologies. Because we always said when there are multiple pathologies, we detect the lateral pathology more closer to tympanic membrane is what we detect using a tympanometry. So here we can identify multiple pathologies. That is really a biggest plus point, I would say.
I think this is a future. My only worry is in the future, people will wait for the instrument to tell, okay, this is otosclerosis, this is this, this is that. They won't bother to look at the
I think the way you do require more of thoughts here to decide. You don't have like a standard A-type tympanogram otosclerosis. You really have to look into the graph and then say whether stiffness is affected, mass is affected, and then correlate it with the pathology. So I think it gives more food for your thought is what I would think.
No. It will give more food, but then they will simplify it. I'm just seeing future. That's what they do sometimes.
Yes, Madhuri, we got a project somebody sent here to assess it. It talks about using artificial intelligence and the convolutors, logistic solution to interpret the results. They think of that, and they say they can teach the machine to interpret the result, and they say, yeah, it is better than a specialist, it says. So that they're having a project, yes.
Then we become technicians.
Yeah, happen.
For example, newborn hearing screening uses the ABR technology. It is, you don't interpret, it says pass or refer. So it is already there in some state.
But for our generation, it will be exciting. We will pass out by the time it comes.
No, but even in infant screening, I always say buy an instrument in which you can see the graph, and plus it says pass or refer, so we can make sure whether what the instrument saying is correct or not correct. Because we do know the problems there was with Algo 1 initially, what problems they had.
Yeah, at this stage, and also another thing is we don't have objective criteria for all the different pathologies. For example, for autosclerosis, there are one or two studies that have identified the objective criteria. For OME, they have starting to identify absorbance at different frequencies and the cutoff ranges. But we still are very far away from even saying whether it's in pathology based upon just the objective results yet. So at this stage, it's a lot on the subjective interpretation. So yeah, we're very far away from that, Madhuri.
Yeah, I only understand that C1 and C2, which we used to do. None of the kids understand what is compensating for what. They don't know everything.
So thank you so much, Dr. Sreedevi and Dr. Venkatesh, Aithal, for helping us with this webinar series. It was very generous of you to accept our proposal and invitation, and helping us with this small endeavor that we've started. It was genuinely one of the most comprehensive, talks that I have heard personally on wideband immittance. I thought of reading the book again from Shehnaz and Polka, but I think I will skip it now because you've covered everything that I would probably read anyways. But thank you so much again.
Thanks for the opportunity, Imran. Thank you.
Thank you.
Thank you.
Yeah, thank you all.
Thank you.
Thank you.